Hi everybody, my name is Alison Hoens. I had the pleasure of just finishing my first interview just a few minutes ago, and I'm pleased to be able to welcome for the second interview this over the lunch hour, Dr. Dafna Gladman, who's from Toronto. And Dr. Gladman, I'm wondering if we could just begin with, if you could share with everybody what it is that you do and why you chose to do it.
So I'm a rheumatologist, currently at Toronto Western Hospital in Toronto. I'm actually celebrating my 42nd year in rheumatology.
Congratulations.
And why I went into rheumatology is an interesting story, because I was in my first year of general medicine training at the University of Toronto at the Wellesley Hospital.
Yes.
And I invited two of the younger staff and my colleagues, interns and residents at my level, for dinner. And the two staff people were asking my husband, what would I like to do as my future career? And he said, since she came into contact with you guys, she might go into rheumatology. And so the next thing I know, those two guys are in my kitchen while I'm preparing for the dinner, and they're making me a 4-year plan of rheumatology.
You didn't know it was happening.
No.
Your life was being planned.
I had no idea.
Okay.
And so after they left, I said to my husband, what did you tell them? And he told me, that's what he told him. I said, why did you tell them that? He said, you know, this was your 6th rotation of the year. The 5 previous rotations, you went to work, you came home, you said nothing. Mm-hmm. This rotation, you went to work, you came home, you told me about the doctors, you told me about the patients. I figured you really liked it.
Interesting.
And that's how I got in.
You know, what we hear generally from people is usually it's others that help us to find our path, help us to find our direction, our journey. But it's not that unusual also that it's over food. Food seems to be a unique way of bringing
the truth is I was always interested in immunology. In fact, I was going into the immunology program. And when I was the first-year resident at the Wellesley, my colleague, Dr. Keystone, had just switched from immunology to rheumatology. So I also thought at the time that, I mean, if he's not even staying in rheumatology, in immunology, and the majority of the research is being done in rheumatology, then why should I go into immunology? And then when that happened, these guys the next day came and took me over to the chief, and the chief signed me on. And
it was a done deal.
That was a done deal.
I have a question just for my own edification here, as well as maybe I'm not the only person. Can you give us a little explanation of the difference between immunology and rheumatology?
So immunology is the area that deals with the immune response.
Okay.
So it's not specific to any particular system in the body, because you have immunology is functional in asthma, in kidney disease, in diabetes, and now they're even in heart disease and even in other conditions, inflammatory bowel disease. Rheumatology is the study of the joints.
Yes.
Not like my son, when he was 4, they would ask him, what does your mother do? He'd say she collects rooms.
Oh, rheumatology.
Exactly.
Yes, I can see that. Yeah.
But so rheumatology specifically is a specialty that deals with inflammation in the joints. Now, there is a direct relationship because the majority of the rheumatologic conditions are actually based on some immune dysfunction.
Yes,
and
they're
so
related, is what you're saying.
They are related, exactly.
Yes.
And so many of the people that practiced or went into some of the rheumatological conditions, became experts in those areas, had actually trained as immunologists. And rheumatology is relatively a young specialty. It's only, the first specialty exam in rheumatology was 1973 in Canada.
My goodness.
And I think the original rheumatologists, Wally Graham, Meadow Grislow, there's another guy whose name I forget, but anyways, they were like in the 40s. And most of these other conditions were known in the previous century.
So you've seen, I would think, over the 42 years, I think you have said, in rheumatology, and this year's conference, for example, the theme is around precision medicine.
Yes.
And that precision medicine is relevant to immunology as well as rheumatology. When you listened, when you've been here over the last day and a half, what are the key messages that you're picking up from your colleagues that you're going to take back to you?
So, I mean, it's interesting for
Toronto.
me that they've picked up that concept as the theme for the meeting, because that's what I do.
Yes.
So I have two areas in rheumatology that I've actually concentrated on. One is lupus,
Yes.
and the other one is psoriatic arthritis. And in both of these areas, this is precisely what we're looking at. We're trying to identify uniqueness of individuals so that we can direct treatment appropriately. And so much of the research that I do in psoriatic arthritis, for example, is doing exactly that, precision medicine, looking for biomarkers for susceptibility, for disease activity, for progression, for treatment.
How close do you think we are to that? And specifically, because I know every disease, it's kind of different. We're all like at different stages in that. What would you say for psoriatic arthritis versus lupus, maybe comparatively? Are they at the same point?
I think we're closer in psoriatic arthritis than lupus, because psoriatic arthritis is unique in the sense that it almost has a substrate. Because 90% of patients with psoriatic arthritis already have psoriasis. So you can study the patients that have psoriasis and say, well, why do some people develop psoriatic arthritis and some don't? And so you can identify some biomarkers there, right? So from that respect, it's easier. Whereas in lupus, you only start when you see the patient. Now, sure, some of the patients have antibodies, but short of doing what some of our colleagues did in the VA system in the States, where they went into the military,
veterans, yes.
When they went into the military and identified people that had abnormalities in their blood, and then followed them over the years and identified who developed lupus.
Well, that's when they refer to prospective studies, that they follow people from a point and they continue to follow them.
So nobody does that on a regular basis, right? We don't sort of check our patients and then follow them over the next 30, or never mind patients, people.
Yes.
And follow them over the next 30 years.
Unless you're in the military, and then you're subjected to whatever.
Exactly. So the point is, in lupus, it's a lot more difficult.
Yes.
And it's also likely that lupus is not one disease, but more of a syndrome where there are many things occur that actually end up with some similar manifestations. And so that's why I think lupus is going to take a little bit longer. For psoriatic arthritis, I'm actually really hoping that over the next 5 to 10 years, we actually will be in a much better position to identify what drug for what patient.
Wow, that's a phenomenal number. I mean,
I don't know that. I mean,
we're not guaranteeing that.
Exactly.
But that's very encouraging.
I often tell my patients that when I got a license to practice, I didn't get a license to prophesy. But I'm hoping that, because
That's wonderful. I mean, we often hear numbers of 10 to 20 years.
I'm really hoping that over the next 5 to 10 years we're going to be really, really that much closer to identifying things.
That's wonderful. I'm wondering, maybe as a final question before we hear if there's any other questions from people who are listening in at the moment. From your work, when you have studied patients with psoriatic arthritis and or the patients with lupus, what would your key messages be to them about, as you're looking at this, moving towards that individualized therapy? What kinds of steps can they take themselves now to, I guess as a patient, we often don't, are somewhat confused about how much we should, what do we say to our rheumatologists? What do our rheumatologists need to know? And what is just, we don't want to say too much.
Okay. So I often tell my patients, this is your opportunity to complain, right? Because if you're going to complain at home, nobody's going to listen to you. When you go to the doctor, is when you have your opportunity to tell the physical, particularly, but others, components of your health. And so I would say that because as a patient, one has not read the books, one has not gone to medical school, one does not know what's relevant and what's not relevant.
That's the key point.
So it's better to tell the doctor everything that's wrong, everything that is not normal. Let the doctor synthesize what's important and what's not important. And the doctor may say to you, this is relevant, this is not relevant. And I often tell my patients, just because you have arthritis doesn't mean you're protected from what the rest of the world gets, right? So people get colds, people get degenerative disc disease, sciatica, things like that. So our patients get those things too. And these are not necessarily part of the inflammatory condition. But if the patient doesn't complain to me, I don't know if they don't have a particular issue, which is part of the inflammatory condition.
That's very reassuring, I'm sure, not just for myself, but for others to hear. Because we don't want to, I often hear from my rheumatoid arthritis colleagues that we don't want to be too much of a burden in knowing, but what I'm hearing you say is say everything and trust that the rheumatologist wants you to, so that they can help to figure it out.
I think that's the only way. Rheumatology, one of the problems with rheumatology is that a lot of the time it's not like diabetes. You have a blood sugar and you can measure the blood sugar. Or if you have a high blood pressure, you measure the blood pressure. But in rheumatology, it's a lot of it is like a puzzle. And you have to have all the pieces, all the right pieces. You have to put all the right pieces together the right way before you see the picture. And if the patient doesn't give you the pieces, you've got nothing to work with.
So it sounds like we need to be sharing as much as we can.
Absolutely.
Anita, are there any questions from our audience?
Yes. Do you have any lifestyle tips for people living with lupus?
I'm sorry, I didn't get the first one.
Do you have any tips for people?
Lifestyle tips.
Lifestyle?
Yeah.
I think the lifestyle tips that I would give a lupus patient is the same as the lifestyle tip I would give any person. You want to have a healthy lifestyle, which includes appropriate dietary intake. Not too much of a good thing is not good, but not enough is not good either. You want to participate in an exercise program as much as you can, and even if you have joint pain or other limitations, you do whatever you can within the context of your life. If you can, you try and avoid stress. Now, if anybody knows how to do that, they should tell me. We'll put it in a bottle and we'll sell it. But generally speaking,
I'll buy shares.
Yeah, generally speaking, if someone knows that there are certain things that are, quote, bad for them, try and avoid those situations. If you're really,
or at least control them.
Or at least control them. I mean, somebody who's really gets stressed when they're in a hurry, try and plan in advance. Don't rush. The little things like that aggravate the underlying disease, because here's where immunology comes in.
Yes.
Because stress affects the immune response in the same direction as the inflammatory arthritis does.
Fuel for the fire.
Exactly.
Are there any other questions?
How are symptoms different between rheumatoid arthritis and lupus?
That's an interesting question. So rheumatoid arthritis symptoms are primarily joint symptoms. So there is pain in the joints, there can be swelling in the joints, there's stiffness in the joints, and those are basically the symptoms that the patient with rheumatoid arthritis complains of. Lupus can have those symptoms as well, because one of the manifestations of lupus is inflammatory arthritis. But on top of it, lupus is a multi-system disease, so there are a lot of other systems that can get involved, including the skin, the heart, the lungs, the brain, the kidneys. Now, while we don't actually feel the kidneys until they are really in trouble, you can see a skin rash, you can have chest pain or shortness of breath, you can have headaches and seizures and things that reflect some inflammation in the brain. So there are a lot more symptoms that occur in patients with lupus than in patients with rheumatoid arthritis.
So there's overlap, but there's more.
There is overlap, but there's more.
Any other questions, Anita? That's it. I want to thank you again for your time today, Dr. Gladman, and I wish you all the best for your presentation on Saturday.
Thank you.
Could you just give us a tantalizing bit of what you're going to cover on Saturday?
So they call it the year in preview. And the instructions that I got is I need to kind of project what's going to happen next year, prophesy.
Prophesizing.
Anyway,
Okay.
so I'm actually talking more about psoriatic arthritis, and I labeled it out with the old, in with the new. Just talking about what I think is going to evolve in the next year.
I will be there. I look forward to hearing
Okay.
your prophecies. Thank you.
Take care then.